So before any surgery, we're going to do a preoperative evaluation, and this is very important because we want to know what the patient's risk is. Obviously, any medical intervention carries with it a certain level of risk, and this is particularly true for surgical interventions. So the preoperative evaluation is an assessment of overall risks that may complicate the operative period and the post-operative recovery period. During the preoperative evaluation, what it consists of is a thorough history, which includes a past medical history, a family history, a social history, and a surgical history, a thorough physical, basic labs, which at least include CBC and CMP, and an EKG are all needed on all patients at a minimum. Some patients will have more labs done, but at a very minimum, we're going to be getting a CBC, CMP, and EKG on all patients in addition to a history and physical. The most critical systems that you're going to need to be mindful of are cardiac, pulmonary, and hepatic systems, as well as the patient's nutritional status. But we'll go over all of the systems and the different complications that they can present. Know the major risk factors for operative and post-operative complications. So these are the systems we're going to cover. So the cardiac assessment, in general, all patients are going to get an EKG before surgery, and this is done to detect any subclinical arrhythmias. Remember that a lot of the anesthetics that are used, they do have arrhythmic potentials, so it's very important for the anesthesiologist to know if there's any kind of subclinical arrhythmia so that they can make appropriate decisions beforehand. The major cardiac risk factors, and this is in order here of most severe, are congestive heart failure, a recent MI within the past 6 months, hypertension, and arrhythmia. So patients who have congestive heart failure, either documented or symptomatic, should have their ejection fraction assessed, and this is done by echocardiogram. Remember that a normal ejection fraction is greater than 55%. Patients with an ejection fraction of less than 35% will never get surgery. So that's an important number to remember. Ejection fraction less than 35%, absolute contraindication for surgery. Patients who are between 35 to 55%, or even patients who may be less than 35%, you can try to medically optimize them to try to get it as high as you can. And so you would do this with ACE inhibitors, beta blockers, and diuretics, or you can use digitalis, but diuretics are probably better. So ACE inhibitors and beta blockers, diuretics, or digitalis. And this is done for patients who have an ejection fraction that's low, or even lower than 35%. We want to get their ejection fraction up as high as we can get it. But remember primarily that an ejection fraction less than 35% is an absolute contraindication for surgery. You'll never operate on those patients. Patients who've had a history of an MI in the past 3 months will generally not be operated on. It's preferred to get outside of that 3-month period, but most preferably to get the patient outside of the 6-month period. So the 3 to 6 months is kind of a gray area, but we're generally never going to do an operation on a patient who's had an MI within the past 3 months. With hypertension, patients with hypertension, it's preferable for this to be tightly controlled prior to surgery. Hypertension increases the risk of bleeding and hematoma formation. Patients with valvular heart disease have an increased risk of postoperative endocarditis. Patients with implanted pacemakers, this is kind of a tricky one. You should probably consult with their cardiologist. This is because a lot of times surgeons use electrocautery as a way to stop minor bleeding. And with the electrocautery, it can create an electric field that can interfere with the pacemaker. So any patient who has documented implanted pacemaker, you should get a hold of their cardiologist and get in touch with them. It's preferable to avoid using electrocautery. Okay, so this is a risk index for cardiac disease that's used by surgeons. Don't memorize this, but what I want you to get from this is the risk factors for surgery as far as cardiac risk factors, and how they kind of rank relative to one another and what that means. So jugular venous distension, which would be a typical feature of congestive heart failure, is 11 points. Okay, and if you look here, the risk, what we've got is this risk of complication and mortality. 0 to 5 points would be less than 1%, 6 to 12 points would be 5%, 13 to 25 points would be 11%, and 25 points or more is 22%. So already there, if you have congestive heart failure and it's not treated, you already have a risk of complications and mortality of up to almost 5%. So that right there is why we don't operate on them if they're not fixed. So jugular venous distension is the #1 risk factor. MI in the last 6 months, again, that puts you right in the risk area, about 5% almost. So that's again why we like to get out of that 6-month period. The arrhythmias, including premature ventricular contractions and non-sinus rhythm, those are 7 points each. Age greater than 70 years, that adds 5 points. Any kind of emergent surgery adds 4 points. And then aortic valvular stenosis, poor medical condition, or any kind of surgery to the thorax or abdomen, those are 3 points each. So you can see here that in your older patients, it's quite easy to get up into that 5, even 11% range, to where you have a 1 in 10 chance of having a significant complication that will likely lead to mortality. And these first 3 up here, jugular venous distension, meaning congestive heart failure, recent MI, or arrhythmias, are the ones that will get you there the quickest. So very, very important to know the #1, #2, and #3 risk factors being congestive heart failure, recent MI, and arrhythmia. But don't memorize this table. That's not important for the USMLE, but it's good to be aware of what the major cardiac risk factors are. The pulmonary assessment centers around the presence or absence of COPD. If a patient does not smoke, doesn't have COPD, for the most part, barring any other major medical conditions, you can assume that pulmonarily they are fine for surgery. However, if the patient smokes or if they have a history of COPD, you should absolutely get pulmonary function tests, and what we're looking for here is their FEV1. So we're concerned with obstructive diseases when we're operating. If their FEV1 is low, meaning less than 80% of predicted, remember that the normal FEV1 is 80 to 120% of predicted, you should get ABGs, arterial blood gases, and in that case then you'll be looking for their partial pressure of CO2. If their partial pressure of CO2 on their arterial blood gas is high, which would be greater than 45 millimeters of mercury, remember the normal range for PCO2 is 35 to 45 millimeters of mercury, then the patient should stop smoking for 8 weeks. They should do pulmonary exercises like incentive spirometry. You can prescribe them a mucolytic and then recheck 8 weeks later. So here's, I got it written out here in a diagram. For me, it's easier to visualize it like this as opposed to words. So if the patient's a smoker or has COPD, you get the pulmonary function tests. If their pulmonary function tests are less than 80%, then order the ABGs. If the ABGs show a PCO2 of greater than 45 millimeters of mercury, you're not going to do the surgery. You're going to have them stop smoking, do some pulmonary physiotherapy and mucolytics for 8 weeks, and then repeat. Now, I want to add particularly here that if they have normal pulmonary function tests, meaning greater than 80% FEV1, you don't need to get ABGs. So you do the PFTs first. If they're normal, you can do the surgery. The hepatic assessment is important because hepatic disease can directly increase the risk of bleeding and reduce wound healing, reduce the rate of wound healing, and because various hepatic factors interact with the patient's mental status and can create problems that way. So any patient should have liver function panels. So that's done in the CMP. And prothrombin time should be obtained in most patients. I would say you can reserve the prothrombin time to patients who have bleeding disorders or who are on things like Coumadin, warfarin, etc. So we're going to be focusing on 3 or 4 parameters here, and that's going to be the total bilirubin, the albumin, the ammonium, and the PT. Now, as a general rule of thumb, if any of these are abnormal, they should be corrected before surgery, especially the ammonium. So patients who have an ammonium that's elevated, meaning about greater than 150, that's an absolute contraindication for surgery because these patients are generally in hepatic encephalopathy. And the mortality rate for patients who get surgery who are in hepatic encephalopathy is about 80%. So 4 out of 5, that's pretty bad. So any of these values, total bilirubin, albumin, ammonium, or PT, should be corrected prior to surgery. The one significant exception would be if the total bilirubin is elevated and that's due to a suspected obstruction. In that case, you would have a jaundiced patient, you'd have an elevated T-bili, you'd think, oh, gee, I should maybe not do surgery. But in that case, you can go ahead with surgery. So remember that in these patients, it will always be an elevated conjugated bilirubin. So when you break down the bilirubin, the total bilirubin, into your direct and indirect, this would be an elevated indirect bilirubin. And this would be caused from things like stones and stuff like that. Nutritional assessment. So in practice, this is going to be relatively obvious most of the time based on the patient's outward appearance and history. Primarily where you see nutritional factors coming into play are patients who have cancer. So these are patients that could have a significant unintended weight loss within the last 3 months. Now, obviously, if the patient has lost weight and they've done it intentionally and healthfully, not a problem. We're talking here about unintended weight loss. So unintended weight loss of more than 20% in the past 3 months, that's a red flag. Other lab parameters that would suggest nutritional deficiency would be your albumin level, if that's low, your hemoglobin, if that's low, and iron studies indicating a high transferrin. Both of those would point you towards iron deficiency anemia, and that can be a sign of a nutritional deficiency. And then the presence of allergy to skin antigens. I don't know how often that is actually done, but that's another thing that can suggest nutritional deficiency. Patients who have suggestive nutritional deficiency should receive intensive PO nutritional support at an inpatient setting for at least 5 days prior to surgery. And this is going to be done based on what how emergent the surgery is. Obviously, if it's an elective surgery, something like gastric bypass, you would go more towards the 10-day side of that. If it's an emergent surgery, then you might not worry about it at all. So this is more geared towards elective surgeries, but important to be aware of. The metabolic assessment primarily focuses on diabetes mellitus and its complications. If a patient is in diabetic ketoacidosis, they will not get surgery. You will never perform surgery on a patient who is actively in diabetic ketoacidosis. You always need to address DKA before any surgical endeavor. And DKA, we're not going to talk about how you manage that here in detail, but it's managed with fluids, IV insulin, and electrolyte supplementation with frequent monitoring of the blood pH. Once we get that in rein, then we can go ahead with the surgery. But you need to address the DKA before any kind of surgical option endeavor. In general, diabetes mellitus, particularly advanced diabetes type 2, presents complications with wound healing and a propensity towards post-operative infections just because of the chemotaxis of the white blood cells. The use of epinephrine for surgical purposes should be avoided in these patients. So where do you see this? You can see this in outpatient surgeries, like if you're taking off a mole, or if you're taking out a cyst. Even family doctors may do this. A lot of family doctors will inject epinephrine along with the topical anesthetic, and that's done because it reduces bleeding. The epinephrine causes vasoconstriction, and it reduces bleeding, and that may be convenient, but patients with diabetes mellitus, you don't want to reduce the bleeding because they already have a certain level of vasoconstriction and problems that way. So you'd want to avoid using epinephrine for surgical purposes in patients with diabetes mellitus. Important to remember also, as long as we're on the topic of metabolic disorders, patients who are requiring long-term corticosteroids, for instance, patients who have hypoadrenalism, like Addison's disorder, they're going to need an increased corticosteroid dosage during and after their surgery, just because you're placing a stress on them. So with this, you don't need to know the exact dosage, certainly not for the USMLE. You should be in consultation with endocrinology. But remember that patients who have hypoadrenalism will need an increased dosage of their corticosteroids. Other things that can come up: neurological, patients who have a history of stroke. Most of these patients are on anticoagulants. That's the important thing to know there. So any patient with a history of stroke, remember that a stroke is, all patients after they've had a stroke are going to be put on Coumadin. So very, very important to know that these patients are probably already on anticoagulants, so you're going to need to check their INRs before you go ahead with the surgery. Also important to remember that accelerated hypertension while you're doing the surgery is a sign of possible stroke, and that's always an absolute indication to terminate the surgery. Patients who have seizure disorders, you're going to want to inform anesthesia. They may want to optimize or alter their anesthesia protocol for those particular patients. And then patients with sleep apnea or snoring, you may want to inform anesthesia of that as well, because those patients might need extra supplemental oxygen, and some of these patients may be difficult to intubate. Hematologically, it's generally advised to normalize the PT and PTT prior to surgery, so get the INR usually down to 1.2 or less, roughly. It's going to really depend on where you're operating, but the general rule of thumb is if you're less than 1.2, you're pretty good. Regardless, you're going to want to have fresh frozen plasma, platelets, and packed red blood cells ready so that in case there is any kind of bleeding, diathesis, or hematoma, hemorrhage rather, during the operation, that you've got your bases covered. Obstetrically, mostly what we're looking at here is a risk stratification. For the USMLE, I wouldn't suspect that you'd be asked whether or not you're going to operate on a pregnant woman. That's a relatively complicated decision to make. The rule that you need to know is that you're going to postpone all elective surgery until after delivery. So we're certainly not going to do a gastric bypass on a woman who is pregnant. That would be silly. Okay, and then skin. Big thing here, just remember that surgery is a stressor, so it can cause exacerbation of herpes, reactivation of herpes, discoid lupus, psoriasis, among other skin diseases. Certain allergies. Some patients are allergic to various anesthetics. Some patients are allergic to antibiotics. We're going to talk about antibiotics, giving those before surgery. You'll have to keep that in mind. Some patients are allergic to certain analgesics, and then, of course, latex. You're going to want to make sure that you know if the patient is allergic to latex. So make sure that you're aware of any of the patient's allergies prior to surgery. As far as giving the patient antibiotics preoperatively, I like to just fall under the assumption that we should just give it to them. I mean, it's very difficult to cause any complications by giving somebody an oral antibiotic. For the most part, what you do, you just give them just one dose of a first-generation cephalosporin, usually Keflex or cefazolin. And, I mean, you can't really cause any complications from that. So, in general, it's just a good rule of thumb to give them the prophylactic antibiotic. What we're doing here is we're reducing the risk for wound contamination. But there are some surgeries that it's optional, but for many it's required. Like I said, it's better to just, since it's optional for some but required for some, it's in general best to just err on the side of giving them the prophylactic antibiotic. Now, first-generation cephalosporins are generally what are used, but if the patient is allergic to first-generation cephalosporins, and 10% of penicillin allergic patients are, then you can give them vancomycin. And with that, you are ready to operate on the patient.